some nerve with faculty discussants Dr. Kendall Donaldson and Dr. Andrew Rong. Dr. Foley.
Thank you so much. I'm Lindsay Foley. I'm one of the cornea fellows here, and I will be presenting You've Got Some Nerve. I have no financial disclosures. Okay, so let's start our case. In June 2019, a 58-year-old is referred by an outside ophthalmologist for complaints of blurry vision in the left eye. The patient has a history of type 1 diabetes, as well as a history of zoster ophthalmicus with extensive V1 involvement to the left side 7 years prior. In 2016, the patient had combined cataract and glaucoma surgery for uveitic glaucoma. Currently takes difluprednate once a day, dorzolamide timolol, artificial tears as needed, and prophylactic valacyclovir. On exam, vision is 20/20 in the right eye and best corrected vision of 20/30 in the left eye. In the left eye, the patient has a stromal scar with some central thinning. On topography, you can see some irregular astigmatism in the left eye with some central steepening and then some flattening inferiorly. Given that the eye is otherwise quiet, the patient is continued on the drop regimen and referred to optometry for a scleral lens evaluation to help with the vision in the setting of corneal scarring. About a month later, the patient sees optometry and was determined to not be a good candidate for scleral lenses due to very low endothelial cell count in the left eye. The patient is then managed by the outside ophthalmologist for the next 2 years. And on November 20th, 2021, she's referred back to the emergency room for evaluation of worsening vision and progressive corneal thinning in the left eye. The vision is now 20/80. The patient is not complaining of significant pain. And on exam, there's a central corneal epithelial defect with about 50% thinning, some anterior stromal scarring without any infiltrate. So in terms of creating a differential diagnosis, would one of the residents be able to help me?
Good question, Dr. Snow. I think you're up to it.
Okay, so the fact that she's not in much pain and has a non-healing KAD, I think of like a neurotrophic ulcer KAD. So differential for that, you can think of severe dryness, some sort of exposure, previous thermal or chemical injury, any cause of limbal stem cell deficiency. Also, you could think of a history of herpetic disease. Probably start there.
That's excellent. Thank you. So the differential of a corneal epithelial defect in the absence of significant pain is broad, but like you mentioned, it includes dry eye disease, topical drug toxicity, exposure keratopathy, contact lens related keratopathy, some sort of chemical injury, some active herpetic corneal disease, other forms of infectious keratitis, as well as limbal stem cell deficiency. So at this point, the outside ophthalmologist has already been managing her for neurotrophic keratitis and has treated her with a full 8-week cycle of Senogermin, which was completed a month prior to this presentation, followed by then 3 rounds of dehydrated amniotic membrane, most recently 2 weeks before she came to the ER. In terms of medication, she's currently using her eye drops for glaucoma, as well as some antibiotics and Valtrex 500 milligrams every day. At this point in the ER, they replaced the dehydrated amniotic membrane as well as the bandaged contact lens, increased the Valtrex to a treatment dose of 1 gram 3 times a day, and initiated the process to attain autologous serum tears. Over the next several months, she starts the serum tears, has a few more amniotic membranes placed with BCLs. Another course of oxyrvate was considered, but she was unable to get insurance approval. She does slowly start to improve. The epithelial defect closes, but then reopens with persistent thinning. And at this point, in May 2022, she's referred to an oculoplastic surgeon to consider tarsorrhaphy as well as an evaluation for corneal neurotization. So she's seen for an evaluation. Her Cochet-Bonnet esthesiometry scores are 0 in all quadrants, and she has good sensitivity to pain in the left V1 distribution. It was determined at this point that she was a good candidate for neurotization with ipsilateral nerve transfer and allograft to the left side with a tarsorrhaphy. She has the procedure a few months later in August. So now let's take a break from our patient and talk a bit more about corneal neurotization. So this is a surgical technique that was first published in 2009 by Terzis et al. He described a direct corneal neurotization approach, which consisted of transfer of the contralateral supratrochlear and supraorbital nerves directly to the corneoscleral limbus of a neurotrophic cornea, yielding substantial recovery of corneal sensation. Since then, others have achieved similar results using variations of the direct neurotization technique using the ipsilateral or contralateral supratrochlear, supraorbital, or infraorbital nerves, as well as indirect techniques using an interpositional graft, such as the sural or auricular nerves, between the donor nerve and the neurotrophic cornea. So here's a short video demonstrating the neurotization surgery with an ipsilateral allograft from the supraorbital nerve.
A blepharoplasty incision is performed and dissection occurs one plane at a time, through the orbicularis oculi muscle, then through the orbital septum, and down to the orbital rim where the supraorbital nerve is identified. An incision is made along the medial brow. A blunt push and spread technique releases the supraorbital nerve from adjacent periosteum and ligaments until the nerve is exposed in the dorsal subcutaneous plane. A second incision is made within a forehead wrinkle approximately 3 centimeters above the brow, and the subcutaneous plane is dissected further. The nerves are then isolated with 4O silk and cut at their distal ends. A needle is advanced through the distal end of the neurotomy sites to create a neural hitch, and the nerves are passed through to the supraorbital rim. The most distal portion of the supraorbital nerve dissection measures 3 centimeters above the brow incision. The branches of the supraorbital nerve are then passed through an incision site made in the supramedial conjunctival fornix and down to the corneal limbus. The branches of the nerve are cut to portions which appear viable. The longest branch of the supraorbital nerve is sutured to the 9 o'clock limbus, while shorter branches are sutured to approximately 10 and 12 o'clock positions with 6O plane cut.
So here I wanted to run through some of the common causes of neurotrophic keratitis. The most common cause is herpetic infection, which occurs in about 6% of patients that have HSV keratitis and 13% after zoster keratitis. Since the cornea is innervated by the trigeminal nerve, it can also occur after surgery for trigeminal neuralgia. Systemic conditions like diabetes, MS, certain congenital syndromes, as well as leprosy can also cause it. And then numerous other causes of corneal sensitivity impairment like chronic dry eye, chemical burns, physical injury, or chronic use of topical medications. When there's impairment in the trigeminal nerve innervation, this has 2 downstream effects. There's an impairment of trophic supply to the corneal nerves, which causes alteration in the epithelium, as well as impairment in corneal healing. There's also impairment of the trigeminal reflexes, which results in reduced tear film production and blink rate. These mechanisms all lead to spontaneous breakdown of the corneal epithelium. NK staging is based on the severity of corneal epithelial and stromal involvement, ranging from superficial punctate keratopathy to persistent epithelial defects and ulcers. The Mackey classification is used to categorize NK into 3 stages: mild, moderate, and severe. But there's some degree of reduced corneal sensitivity that's present in all of the stages. At stage 1, the goal is to improve the corneal epithelium and prevent breakdown. Ways to do this include discontinuing offending topical and systemic medications, as well as topical lubrication. At stage 2, you may consider starting topical antibiotics, steroids in certain cases, serum tears, tarsorrhaphy, and conjunctival flaps. And at stage 3, one can consider use of amniotic membranes and therapeutic contact lenses. When interventional treatments are needed, there are numerous non-surgical options. Eyelid closure can be accomplished by a number of ways and protects the cornea from desiccation, as well as from mechanical blinking trauma. Punctal plugs can help retain natural tears. Therapeutic soft or hard contact lenses can act as a physical barrier against mechanical trauma. And tissue adhesives can help seal small defects or perforations. And then there's also many other treatment options we're all familiar with for concomitant dry eye disease. In terms of surgical options for intervention, amniotic membrane can be used for non-healing corneal ulcerations. Tarsorrhaphy can be very helpful, both temporary and permanent forms. Corneal transplant can be performed. However, this is usually reserved as a last resort when corneal ulceration has failed to heal, since there is a high risk of rejection, failure, and melting in neurotrophic keratitis patients. And then lastly, of course, corneal neurotization, which is the only procedure that directly targets the ophthalmic division of the trigeminal nerve to restore normal corneal sensation. This is a review article that was published in 2020 by Liu et al. In a multi-institute collaboration. They looked at 45 articles reporting surgical techniques and outcomes of corneal neurotization surgeries. One case series they looked at found an overall success rate of reinnervation of around 80% for both direct and indirect techniques. Several series showed that objective improvement in sensation occurs around 5 to 6 months after surgery, but improvements do continue for about a year after surgery. They also showed that the return of sensation is significant, although not complete when compared to the unaffected cornea. Younger age in this series was also associated with better outcomes. This article from Catapano et al. From 2019 prospectively recruited patients undergoing corneal neurotization, 4 of which subsequently underwent keratoplasty. The timing of the transplants ranged from 24 to 33 months after neurotization surgery. 2 patients had DALK, 2 had PKP. All transplants eventually epithelialized, ranging from 4 to 8 weeks postoperatively. Sensation returned to pre-keratoplasty levels about 6 months later. All but one eye had some level of complication, including recurrent epithelial defects, endothelial rejection, and a microbial keratitis resulting in graft failure in one eye. So now let's get back to our patient. 2 months postoperatively, she was doing well. Vision gets to 20/80. There was no epidefect present, but she did have some central calcific deposits. On Cochet-Bonnet, she scored a 1 supratemporally, but everywhere else was still a 0, although this is expected at only 2 months postoperatively. In December 2022, she continues to do well without an epidefect, so her tarsorrhaphy is opened. So here's a summary of her Cochet-Bonnet scores. Preoperatively, she has no sensation in any quadrant. She again measures with no sensation about 6 months later. But about a year after surgery, you can see that her scores are significantly improved in all quadrants. On September 29th, she sees optometry. And at this point, she's been stable for several months without any epithelial defects. The prior area of thinning has improved significantly. She continues on serum tears and once daily prednisolone. And with the scleral lens over-refraction, she gets to 20/40, although she eventually decides that she doesn't want to wear it. So in summary, NK can be very challenging. Making the diagnosis and initiating treatment as early as possible is important. There are numerous medical, procedural, and surgical approaches available, and most patients will require a combination of these. Interventions should be tailored to the patient's stage of disease, as well as the etiology of their neurotrophic keratitis. And luckily, there are exciting treatments being developed that have the potential to change the treatment landscapes for our patients. I wanted to thank Dr. Donaldson as well as Dr. Rong for sharing this patient with me and allowing me to present this case today. So now let's get to our Zoom poll. So first question, which of the following is not a treatment for neurotrophic keratitis? Option A, eyelid closure. Option B, therapeutic contact lens. And option C, simple limbal epithelial transplantation or SLET. Okay. Question 2, which of the following nerves has not been used for corneal neurotization? Option 1, the supraorbital nerve. Option B, the greater petrosal nerve, or option C, the infraorbital nerve. And then the third question is the Mackey classification is used to grade severity of neurotrophic keratitis and can help guide treatment decisions. True, false, or I'm not sure. Okay. So question 1. Looks like everybody got it right. The answer was SLET. And then for question 2, again, everybody got it right. The greater petrosal nerve has not been used. And then question 3, also correct. The Mackey classification is used to grade stages of neurotrophic keratitis. So good job.
Thank you, Dr. Foley. That was great. I think we have Dr. Donaldson on the Zoom. Maybe we can hear from you first and then introduce Dr. Rong, who's here live in person.
Great. Great. Thank you so much. Can you hear me okay?
Yes, we
Yeah,
can.
we can.
Perfect. That was a wonderful presentation, Dr. Foley. So thank you for sharing that important case. I think we've been drawing more attention to the diagnosis and treatment to neurotrophic keratitis since about 2018 when Sunedrimin was approved. Fortunately at Bascom Palmer, we've had it for about 10 years because of Victor Perez doing some of the early trials with it. But prior to the last, 6 to 10 years, we weren't really paying much attention to neurotrophic keratitis. So I think now we're doing a much better job of diagnosing earlier, thanks to the availability of that medication. And diagnosing earlier allows us to avoid some of the complications, as we saw in this particular patient with corneal scarring, irregular astigmatism, which leads to long-term visual compromise. So it's important that we intervene early to try to avoid some of these issues with long-term vision issues. But we also know that Sunedrimin doesn't work for everybody. And as you nicely pointed out, Lindsay, it only works about 70% of the time because it's a recombinant nerve growth factor, which means we really need nerves present in order to help them to work in that area. So thanks to corneal neurotization, things like this allows us to bring in some healthy nerves. And then perhaps Sunedrimin can work even better if it has healthy nerves there to work from. I think also a lot of times we need to pay more attention to the underlying causes. And you did a nice job, Lindsay, talking about some of the other causes that need to be treated in these patients, identifying the cause of the problem and making sure that that's treated early on in the course. There were some questions in the chat I saw regarding the use of insulin. There are a lot of studies, and insulin has been used in smaller studies. We need larger multi-center controlled trials to really determine the effects of insulin, but insulin can help heal the cornea. So it has regenerative powers in the cornea. It helps encourage epithelialization, and there are a lot of studies going on, but it's not readily available. So that's one thing that hopefully we'll be using more readily in the future. And there's also some research involving insulin-like growth factors that can also help encourage epithelialization. So, we've got a lot of interest in this area, and maybe Dr. Rong could come up more on the surgical aspect here of this case. But yeah, that was a wonderful presentation, a great overview of this problem with NK.
Yeah, I agree. That was a great presentation on neurotrophic cornea. When I was a resident, I always thought this was a really rare condition that, when it would always come to the ER perforated, but as I get, into my career, I see a lot more of the Mackey stage 1, Mackey stage 2, where, these patients, where we can intervene early, we can prevent them from having this melt later on. As you can see, a lot of these patients and a lot of ones that get referred to me, even just for tarsorrhaphies, have gone through, 10 AMTs, 1 to 5 rounds of oxyrvate and they're just, for years and years and years, they just keep getting kind of pushed down the line where they have recurrent corneal erosions. This one patient I remember came to the ER every 3 or 4 weeks just to get a new AMT. It's not a very cost-effective measure of treatment if you think about it. It's a chronic condition. It needs to be treated and thought of as a chronic condition, and intervening early is more important. And that's something that changed from when I was a resident to now what I'm doing. In regards to the surgical procedure, you just saw a direct corneal nervization. And what we performed on the patient was indirect nerve allograft. Actually, in about 1 hour, we're about to do an indirect corneal nervization on a 2-year-old, where we move the sural nerve in for congenital neurotrophic cornea. So, and if you want to see it, it'll be upstairs. But my point being is that this is as I speak to a lot of doctors about this surgical treatment, I think that people think at first this is some very very intensive surgery, that, we're doing some surgery that is extremely invasive, that it's going to have complications. I think that we have to switch our thinking, because as an oculoplastic surgeon, this is not a big surgery. This is not something that we need to really think about, where we have a lot of complications that occur. If you use a supraorbital nerve, yes, if you transect it, you'll have some numbness on the forehead. Even if you do an indirect, end-to-side coaptation, you're not going to have any numbness on your forehead. You can use the infraorbital nerve. There's a lot of nerves you can use, and you don't even have to harvest a sural nerve. Now we can use a nerve allograft, or we use a donor nerve. So this idea that when I speak to physicians that this is something that we have to use as an end result, I think we have to change the way we think. And I've been doing these on Mackie stage 1, Mackie stage 2, because this patient will eventually get to Mackie stage 3. So you might as well intervene early. And, the original studies, if you look at it, show that there's no vision improvement with corneal nervization, but it's only because their cohort had such severe disease at Mackie stage 3 that there's nothing you're going to improve at that point. So I think the way we should think about this condition is, number one, that surgical intervention, there's very few surgical interventions that can cure chronic diseases. And this is one of them. So I think we need to just switch maybe the way we think, or, hey, we can intervene early, we can perform a surgery that is not that invasive, and we can cure the patient for forever of this condition. And that's the kind of thinking I kind of challenge you to change today.
Thanks, Dr. Rong and Dr. Donaldson. Before I go into the audience, any comments, into the virtual audience, any comments from the live audience? There's a question, Dr. Donaldson, maybe you can answer this. What is the secret sauce if you were to put like a collection of drops and orals to help a patient like this? Do you find that something like doxycycline can be a helpful adjunct, or any other agent that's worked well in your hands or in that of others?
Sure. Yeah, I certainly think that doxycycline can play a role as an anti-inflammatory for these patients, especially if they have significant lid disease, meibomian gland dysfunction, things like that. So, every one of these patients is a little different, as we've mentioned here, and some respond better to one thing versus another. And anti-inflammatories, and again, treating the underlying cause, it really has to be taken into consideration, and the treatment approach needs to be customized. However, all of them have in common, the problem with the nerves. And so, treating them in a customized way, intervening early, certainly, we have to take that into consideration. But yes, doxycycline can play a role as well.
And the last question before we move on, in the interest of time, Dr. Rong, you have experience with this, is, the cryopreserved amniografts versus dehydrated. What do you feel like there's a difference between one versus the other, or do you feel like they do the same kind of job to protect cornea, et cetera?
Well, amniotic membrane, or
an amniotic membrane in general, dehydrated versus cryopreserved. Is there a difference?
I'm not sure I'm the best person. I mean, I use cryopreserved just because that's what we use here, but I'm not sure the data on the difference. I'm sure that there's companies that can push me either way about it, but I'm not quite sure the answer to that one.
I would say, we use both types of membranes. Sometimes the cryopreserves can be a little tougher on a patient like this because it comes with a peripheral ring, which could be tougher in a patient to tolerate. So sometimes I like the dried membranes. I think the dried membranes also can sometimes induce a little bit more scarring, which can reinforce an area that may be incredibly thin, that may be in danger of perforation. There might be a little bit more scarring induced by a dried graft.
Great. Thank you so much. Wonderful presentation. We'll now move on to our second presentation, which will be delivered by another of our cornea fellows, Dr. Caroline Lear. She's presenting a case entitled Unmasking Cicatrizing Imposters, and her faculty discussant is Dr. Guillermo Amezcua. Dr. Lear.
Thank you, Dr. Labiad.
I think Alex.
Dr. Lear, just give me a moment. I'll go ahead and I'll get that up for you.
Thanks, Alex. Alrighty, so my name's Caroline Lear. I'm one of the cornea fellows here, and the title of my presentation is Unmasking Cicatrizing Imposters. My faculty discussant is Dr. Amezcua. I have no financial disclosures. So this case presents with an 80-year-old male who was referred to the Bascom Palmer emergency room for progressive irritation for 3 months. He was referred by an outside provider for possible malignancy in his right eye. He had a history of type 2 diabetes and vitiligo. This is an external photo of his eyes. As you can see, he's got irregular pigmentation from the vitiligo. Vision was 20/70 in the right eye, 20/25 in the left eye. These are slit lamp photos of his right and his left eye. This is also an anterior segment OCT of his right eye. Can I get one of the residents to describe the slit lamp photos and also the anterior segment OCT?
Dr. Seeley, what do you think about these?
Yes, we have external photos of the right and left eye and the nose, I think. So in attention's drawn to the right eye, we have temporal, kind of irregular conjunctiva. There's a symblepharon, sort of infratemporally there, maybe 1+ injection, as well as some conjunctivalization of the temporal cornea. Otherwise, cornea looks fairly clear. AC looks quiet from what I can tell in the external photo. Iris is round and regular. Left eye looks maybe some nasal pigmentation, but otherwise looks grossly normal. On the OCT, there's epi thickening and hyperreflectivity, as well as subepithelial hyperreflectivity.
That was excellent. So for this patient, we asked him a little bit more about his past medical history. He denied a history of trauma or chemical burn. He had no known history of Stevens-Johnson syndrome or changes in his medication. He denied a previous infectious or inflammatory conjunctivitis or keratitis, and he had no other autoimmune diseases that he knew of other than the vitiligo. So at this point, we diagnosed him with the cicatrizing conjunctivitis, and looking at the differential diagnosis, bilateral causes usually include mucous membrane pemphigoid, OCP or ocular cicatricial pemphigoid, Stevens-Johnson syndrome, atopic keratoconjunctivitis, ocular rosacea. When you see unilateral presentations, you want to think about malignancy or infectious processes. And then with certain autoimmune and inflammatory processes, there's a lot of overlap, such as with sarcoid or Sjogren's syndrome. You can get unilateral or bilateral presentations. So I'll be talking about cicatrizing conjunctivitis today. These are my objectives. So this is a group of chronic inflammatory eye disorders characterized by conjunctival inflammation and scarring. It involves deeper layers of the conjunctiva, subconjunctival tissue, and tarsus. Etiologies include local and systemic diseases, and they can cause significant visual impairment. So establishing the underlying etiology is crucial in order to target the pathophysiology and treat the patient. In looking at the epidemiology, these were two large surveillance studies based out of the UK as well as Australia and New Zealand. And they estimated the incidence at 1.3 to 1.5 per million. So it's a very rare disease. And in looking at the etiology, they can be divided up into ocular diseases, ocular dermal diseases alone, and then multi-system autoimmune, infectious, and inflammatory processes. In looking more in depth at the etiology, the same paper published in the UK was a prospective surveillance study of newly diagnosed cases of cicatrizing conjunctivitis and found that by far the most common cause was OCP, followed by Stevens-Johnson syndrome. The average time from symptom onset to diagnosis was about 1 week in the case of Stevens-Johnson syndrome. However, with OCP, the time from onset to diagnosis was about 225 days, so much longer. And patients with OCP on average were much older compared to patients with Stevens-Johnson syndrome. So making the diagnosis of a cicatrizing conjunctivitis can be very complex, but breaking it into simple terms, you want to get a detailed history, clinical exam, a laboratory workup, and possibly a conjunctival biopsy. So starting with the exam, patients typically present with vague complaints of burning, irritation, and kind of this vague conjunctivitis that's refractory to conservative treatment. Some of the earlier telltale signs are subepithelial fibrosis, where you get these white kind of glistening strands running parallel to the lid margin, as well as fornicele foreshortening, where these fibrotic membranes preclude visualization of the inferior fornix. As the disease advances, however, you get these more severe signs and symptoms. You get tarsal scarring, symblepharon formation, limbal stem cell deficiency with ulcerization and keratinization of the ocular surface. And unfortunately, once these patients progress to these stages, it can be difficult to determine what the underlying etiology is. So this was a paper published in the Indian Journal of Ophthalmology that looked at some of the distinguishing features of more common causes of cicatrizing conjunctivitis that I'll briefly touch on. So starting with bullous pemphigoid versus mucous membrane pemphigoid or ocular cicatricial pemphigoid. Bullous pemphigoid primarily involves the skin and presents with these tense blisters that eventually rupture into erosions. OCP or mucous membrane pemphigoid primarily involves the mucosal surfaces and less commonly involves the skin. It most commonly presents in the oral mucosa followed by the eye, and it typically presents with mucosal inflammation and erosions. In regards to the eye, mucous membrane pemphigoid or OCP typically has the classic signs of fornix foreshortening, subepithelial fibrosis, and symblepharon formation, whereas with bullous pemphigoid, you get these large granulomas on the bulbar, palpebral, and tarsal conjunctiva. Stevens-Johnson syndrome, as we all know, has a more acute and progressive onset early on and usually has bilateral involvement early on. OCP has more of a gradual, insidious onset with asymmetrical involvement. Usually one eye has more advanced stages than the other. And Stevens-Johnson syndrome usually has early keratinization as well as pigmentary changes of the eyelids and the skin. And then finally, with drug-induced cicatrizing conjunctivitis, you get symblepharon formation more prominent in the inferior and medial parts of the eye, and as well as punctal changes. So moving on to the history, the same paper published in India has this nice algorithm of what questions you want to ask the patient, the onset, whether or not it's been present since childhood, if they've had any trauma or surgery, any cancer or head and neck radiation, if they've had a bone marrow transplant, if they use any topical drops, specifically glaucoma drops, and then if they are having any systemic symptoms, so dry mouth or joint pain, any atopic diseases, and then especially you want to ask them about skin and mucosal involvement. So asking them about GI and GU symptoms, any trouble breathing or dysphagia. And if the clinical exam and the history are not supportive of an etiology, then you want to proceed with a laboratory workup with or without biopsy. This laboratory workup includes a number of inflammatory markers, including ANA, Sjogren's testing, ANCA testing, testing for sarcoid, and getting a chest X-ray or CT scan. And this is to rule out more rare etiologies of cicatrizing conjunctivitis. These were some case reports of Sjogren's syndrome, sarcoid, and a paraneoplastic syndrome presenting as a cicatrizing conjunctivitis. And as you can see, these look clinically indistinguishable from OCP. All of these patients underwent laboratory workup, and it's interesting to note that while many of them did have positive serology, a large proportion of them had a negative workup and were ultimately diagnosed with biopsy, either conjunctival biopsy, as in the case of the paraneoplastic syndrome and sarcoid, or minor salivary gland biopsy in the case of Sjogren's syndrome. So the last step in the diagnostic evaluation is a conjunctival biopsy, and this is a controversial topic for a number of reasons. One is that the sensitivity in the literature for direct immunofluorescent staining is very low. It ranges from 50 to 80%. The biopsy itself can induce inflammation and scarring, and it often does not alter management. Patients are started on immunosuppression regardless of the biopsy results. The biopsy is usually sent in formalin for histopathological analysis, as well as in Michael's fixative for direct immunofluorescence. With OCP, as we all know, you get complement and IgG deposition along the basement membrane. And so there's two schools of thought on whether or not to proceed with conjunctival biopsy. This paper in the Indian Journal of Ophthalmology strongly recommends doing a biopsy in all cases suspicious for OCP. They recommend 2 biopsies in uninvolved areas of bulbar conjunctiva and simultaneously considering biopsying the buccal mucosa to improve diagnostic yield. On the other hand, however, several papers in the literature recommend against conjunctival biopsy. This was a paper published in the AAO looking at the validity of direct immunofluorescence testing that was a diagnostic requirement for OCP. This classification recommending excluding patients with a negative biopsy from a diagnosis of OCP. And the problem with this is that delaying the diagnosis or misdiagnosing these patients can result in irreversible clinical deterioration because they don't get the proper treatment. So they looked at 73 patients with OCP. Only about 30% of them had ocular disease only, so a large proportion of them had other sites of involvement. About 60% had positive direct immunofluorescent results, so about 40% of them had negative biopsies. There was no significant demographic or clinical difference between patients with a positive or negative biopsy result. Asymptomatic disease at non-ocular sites was very frequent, and there's no significant difference in treatment outcomes in patients with a positive or negative direct immunofluorescence test. So they concluded that patients who met the clinical criteria for OCP should be treated with systemic therapy regardless of the direct immunofluorescent results. Oral and nasopharyngeal mucous membrane pemphigoid is frequently asymptomatic, so these sites should be routinely screened in asymptomatic patients and potentially used as a biopsy site. This was another paper published by Dr. Margolis and his colleagues at WashU that also recommended discontinuing conjunctival biopsy with direct immunofluorescence for the diagnosis of OCP because these patients, regardless of the testing results, are treated aggressively to prevent vision loss. So moving on to the treatment, the goal of treatment is to stop the underlying problem in the pathophysiology. So with non-progressive cases, this means removing the inciting insult, whether it's a chemical burn or medication in Stevens-Johnson syndrome. And then with progressive cicatrization, you want to stop the underlying inflammatory process. So starting systemic immunosuppression is key, and this is usually co-managed with a rheumatologist. And in both non-progressive and progressive cases, you want to optimize the vision and the ocular surface by starting aggressive lubrication, steroids, potentially contact lenses, and then potentially surgery. So getting back to our patient, so he ultimately underwent a conjunctival biopsy, which revealed granulomatous inflammation. Anytime we see this, we automatically think about sarcoid, TB, syphilis, or a fungal organism. His GMS stain was negative for a fungal etiology. His Zeal-Neeson stain was negative for acid-fast bacilli, and his Phyte-Verocco stain was negative for leprosy. So he underwent a workup for sarcoid, TB, and syphilis. His sarcoid and syphilis testing was negative. However, he had 2 positive quantiferon tests as well as chest x-ray that was negative. So our working diagnosis for him was a cicatrizing conjunctivitis secondary to TB. We referred him to an infectious disease specialist who started him on isoniazid therapy for latent TB. And we followed him closely to see how he would respond clinically to this treatment. So I'll briefly talk about ocular tuberculosis. Primary infection is when the eye is involved as the initial site of infection. With secondary infection, the eye is involved due to spread from adjacent areas or from a hematogenous source. It can involve any part of the eye, but most commonly manifests as a uveitis. So corneal and conjunctival involvement, historically, the first case was reported in 1873 by Dr. Koester. In 1912, Dr. Iyer published 206 cases of conjunctival and corneal tuberculosis with variable presentations, which I'll discuss in a few slides. With advances in treatment of pulmonary tuberculosis, cornea and conjunctival involvement has become exceedingly rare, and it's typically found in endemic countries. It's more common in the first 2 decades of life, and it presents as a unilateral chronic conjunctivitis that doesn't respond to typical therapy and has worsening symptoms on steroids. And the typical appearance are these subconjunctival nodules. In the literature, the presentation is limited to case reports. And as you can see, it typically presents in patients in their early teens and 20s. Less commonly, it presents in patients in the 5th to 6th decade of life. And as you can see, it also is usually in endemic countries. And it typically presents with this kind of lumpy, bumpy, nodular appearance. In children, however, it typically presents as a flectinule or an inflamed nodule on the cornea and conjunctiva. And this, as we know, represents a delayed type hypersensitivity reaction to the tuberculosis antigen. So making the diagnosis of conjunctival tuberculosis requires a biopsy, a PPD or quantiferon, and a chest x-ray to rule out systemic involvement. With the biopsy, you want to see granulomatous inflammation, usually with caseous necrosis on pathological analysis. And a number of other tests can help aid you making the diagnosis with the biopsy. So the Zeal-Neeson stain looks for acid-fast bacilli. Lowenstein-Jensen culture is more sensitive than the acid-fast stain, but it's very slow to grow. And then if available, a PCR can also aid in the diagnosis, but it has a low sensitivity. And in looking at this algorithm and this diagnostic workup for the treatment and published in this paper in the Indian Journal of Ophthalmology, they didn't really mention, getting a TB or syphilis testing and making the diagnosis of a cicatrizing conjunctivitis. So this just kind of highlights how important it is to get this testing before starting systemic immunosuppression. This was a case series of 6 patients with chronic conjunctivitis secondary to tuberculosis. As you can see, they all had variable presentations. Many of them had this nodular appearance, but several of them had ulcerations in their conjunctiva. One of them also had this chronic papillary reaction. And in all 6 cases, the most consistent finding that supported the diagnosis of conjunctival TB was caseating granulomas on histopathology. The PCR testing, as well as the AFB stain and the culture, were less reliable in making the diagnosis. And then all 6 patients had complete resolution of their symptoms without recurrence on 2 months of an anti-tuberculosis regimen, followed by 7 to 10 months of a 2-drug regimen. So this paper published the diagnostic criteria of conjunctival tuberculosis. It's a chronic or recurrent unilateral conjunctivitis with one of the following laboratory or clinical criteria, either a positive smear or culture or PCR for tuberculosis. positive histopathological findings of caseating granulomas with or without a positive acid-fast bacilli stain, or having a clinical response to anti-tuberculosis therapy with or without systemic signs of tuberculosis. So getting back to our patient, we ultimately diagnosed him with cicatrizing conjunctivitis secondary to TB based on his laboratory results, his biopsy, but also his clinical response to isoniazid therapy. This is what he looked like 4 months after isoniazid. As you can see, he has significant improvement in his symblepharon injection in this conjunctival lesion invading the perilimbal cornea. And it's interesting to note that in the literature, most of these patients were treated with a minimum of 2 months of a 4-drug regimen, followed by 6 months of like 1 or 2 drugs. So it's great that he responded so well to just a 1-drug regimen for 4 months. So in conclusion, differentiating cicatrizing conjunctivitis requires a comprehensive approach that considers the clinical presentation, underlying causes, and the condition's progression. A biopsy and systemic workup are often needed to determine the disease and management. And a chronic unilateral conjunctivitis with pathological findings of caseating granulomas with or without a positive AFB, PCR, or culture is highly suggestive of a tuberculosis infection. These are my references. And now I'll do the Zoom poll. Alex, I can't see it on here. Sorry.
I'll read the questions, Kelly.
Sorry.
Don't worry.
Thank you.
The first question, early signs of a cicatrizing conjunctivitis include symblepharon formation and lateral canthal fibrosis, subepithelial fibrosis and fornicele foreshortening, or limbal stem cell deficiency with persistent epithelial defect. Question number 2, based on epidemiology studies in the literature, which of the following etiologies is the most common cause of cicatrizing conjunctivitis? Stevens-Johnson syndrome, ocular cicatricial pemphigoid, or drug toxicity? And question number 3, keratoconjunctival tuberculosis commonly presents with which of the following features? Papillary reaction, corneal ulcer, or subconjunctival nodules? We'll give the audience a few more seconds to answer these. All right, so Dr. Lear, question number 1. Early signs of a cicatrizing conjunctivitis include, our audience went with subepithelial fibrosis and fornicele foreshortening as their favorite answer, 65%.
That is correct.
Question number 2, based on epidemiology studies in the literature, which of the following etiologies is the most common cause of cicatrizing conjunctivitis? 54% of the audience said ocular cicatricial pemphigoid.
Correct.
Question 3, keratoconjunctival tuberculosis commonly presents with which of the following features? 80% of the audience said subconjunctival nodules.
That is also correct. Thank you.
Excellent. Great job. Dr. Mascua, take it away for us.
Good morning. Excellent and comprehensive review of cicatrizing conjunctivitis. The goal of this presentation was to, just walk us through how we approach a patient with cicatrizing conjunctivitis. So I think in this case, the way to think about it is unilateral versus bilateral. Yes, we don't, when we see cicatricial disease of the conjunctiva, that's not normal and needs to be investigated. And the disease that we don't want to miss is cicatricial pemphigoid because it's a blinding condition and we know it's progressive. But here, when you have a complete unilateral disease, I think the number one diagnosis that we don't want to miss is malignancy. So the biopsy plays a very important role. This patient, I thought it was going to be something malignant, and a biopsy was performed and showed the granulomatous inflammation. And now we have to follow, the diagnostic algorithm ruling the masqueraders. But the topic of the conjunctival biopsy in general and cicatricial disease, it's a very there's a lot of debate about it because of the immunofluorescence is not always very helpful. So I think that the most important thing in a patient with cicatricial conjunctivitis is to take a good slit lamp photo. It is so useful to have good slit lamp photos. And this patient was referred to me by Dr. Basil Williams. He had wonderful photos of how he presented. And then months later coming here, seeing more inflammation. That always helps a lot, just having a ocular surface photography, not just the cornea, but looking at the fornix and superiorly and inferiorly. So to finish, the point that Dr. Todd Margolis makes in his editorial, I think is very important. So the use of immunofluorescence in cicatricial conjunctivitis is very helpful when you have a positive biopsy. The problem is that some physicians don't feel comfortable immunosuppressing, and then they say, okay, we have a negative biopsy. Well, let's just start, topical steroids on cyclosporine, and you're not going to accomplish anything. So if you have a negative biopsy, if you have a patient that has progressive scar tissue, you need to treat systemically. That's the message. So he is in favor of biopsy in the editorial, but a negative biopsy, it's sometimes harmful because the patients don't get treatment fast. So the point at the end is, if you see progressive cicatricial disease and you rule out other autoimmune conditions, with a clinical history, that it's not Steven Johnson, that it's none of the other conditions, and you're thinking about cicatricial pemphigoid, you have to immunosuppress this patient. And of course, ruling out all the masqueraders, so you don't immunosuppress someone with syphilis or TB.
Great. Thank you so much, Dr. Musco. We got a few questions from our virtual audience. And of course, if there's any questions from our live audience, I'll be loving to entertain those as well. But, one question of interest is regarding the testing, quantiferon testing, and what it picks up. Does it pick up other mycobacterial infections or just MTB? The specific question here is, does quantiferon, can Mycobacteria leprae have a positive quantiferon? And does leprae cause cicatrization of the conjunctiva?
I don't have experience with leprae in this, and it may be a good thought because of the vitiligo. But I think it's a good point. I don't know the answer to that.
And for these patients with tubercular conjunctivitis, is there a role for steroid? And if so, when?
Cicatricial conjunctivitis?
Well, with tuberculosis conjunctivitis.
You can, if you do a round of orals, I'm assuming it's systemic steroids, right?
They didn't specify.
So when you have a patient with cicatricial conjunctivitis, and sometimes we use a steroid challenge. I think with TB or syphilis, you're going to get a response. So the patient is going to get better, but at some point it's going to start getting worse. So you need to follow the correct algorithm. So, yeah.
I guess maybe with the anti-tubercular treatment.
Oh, yeah.
And I think they did specify topical steroids. When do you start topical steroids?
There should be no topical steroids as you're doing the systemic treatment, just like with something like syphilis. There's no problem with that.
Great.
Yeah.
All right. Excellent. Thank you so much. Great presentations this morning. We'll turn the program over to Dr. Alfonso to introduce the Clarkson lecture.
Good morning, everyone, and welcome again to Grand Rounds. It's really an honor for us to be able to host this lectureship that has been made possible by our fearless leader for so many years, not just at the Bascom Palmer Eye Institute, but at the medical school too, and in national and international ophthalmology, and that's Dr. John Clarkson and his lifetime companion, his wife Diana. So, if I could have the first set of slides.
I'll try to get them up there. One moment, Dr. Alfonso.
Sure.
I apologize.
I'll take my time. And for us, it's really wonderful to be able to have great individuals that have really made a mark around the world in what they do. Be the guest lecturer in this lecture. So the Diana and John Clarkson Endowed Feature Speaker Series on Advances in Global Ophthalmic Education was started, like I said, by Diana and John Clarkson some years ago. So in May of 2021, Dr. Clarkson, as he usually does in a very unassuming way, said, I want to endow a lectureship that will highlight specialists in global ophthalmic education. And so he and Diana made a significant contribution to the Bascom Palmer Ophthalmic Research Foundation to be able to endow this lecture to honor international speakers from various ophthalmic specialties who have made significant advances in the treatment of eye diseases. So let me tell you a little bit about John. He was born in Grove City, Pennsylvania, went to college at that very bad reputation school called Princeton University. Sorry, Nina. And then did his MD at the University of Miami, his internship at Boston University, and then served in the military, came to Bascom Palmer after that to do his residency, and became a chief resident here at Bascom Palmer, and then went off to do fellowships in ophthalmic pathology and vitreoretinal surgery at the Wilmer Eye Institute, and then came back to do a medical retina fellowship with Dr. Donald Gass. John, from there on, not only became a wonderful faculty member here at Bascom Palmer, but continued to do just tremendous things over his career that spanned more than 40 years. He was the executive director and CEO of the American Board of Ophthalmology. He was our dean emeritus here, chair emeritus of the Bascom Palmer Eye Institute, past president of the AOS, American Ophthalmological Society, and the Macula Society, and authored more than 60 peer-reviewed, highly quoted works. He has been a volunteer in North Carolina after he retired, and has worked continuously to help patients and others with their health and eye diseases. And he serves to this moment as the executive director of our Ophthalmology Research Foundation. John has received almost every award you can think of in medicine, including the National Physician of the Year Lifetime Achievement Award and the Lucien Howe Medal of the American Ophthalmological Society, which is really one of the top honors in ophthalmology worldwide. And that was the same year that John and Diana decided to do that. This was also interesting because John was instrumental in getting some of our colleagues and friends in the community to support ophthalmic education here at the Bascom Palmer Eye Institute. And on the lower right picture, you see John Clarkson with Stephen Getty and myself. And the gentleman behind John is Norman Brayman, who has been a steadfast supporter of community activities here in Miami and nationally. And he was partially responsible for endowing the John Clarkson Chair, which Dr. Steve Getty holds today. Here's John and Diana. They have been married for many years. John speaks highly of Diana, and Diana speaks highly of John. So they're a great couple to be around with. And they both have the DNA of volunteers. Diana doesn't stay behind and certainly does quite a bit of volunteering work in North Carolina. And they have a wonderful family that you see here in this photograph. The Diana and John Clarkson Endowed Feature Speaker Series has had incredible speakers so far. Dr. Juan Valle, Dr. Eduardo Mayorga, and we are very pleased that this year's speaker is our great friend and colleague, Dr. Marcelo Ventura. And I'm going to have Dr. Steve Getty, who's the holder of the John Clarkson Chair, come up and introduce Dr. Ventura and his family. So, Steve.
Thank you, Eddie. Well, it's really a great pleasure for me to introduce Dr. Marcelo Ventura, who is this year's Diana and John Clarkson Lecturer on Advances in Global Ophthalmic Education. Dr. Ventura earned his medical degree from the Federal University of Pernambuco. He completed residency training at Santa Casa de Misericordia University in Sao Paulo, and that was followed by a fellowship in retina and cataract surgery at the University of Puerto Rico. At a later stage in his career, he obtained a master's degree in ophthalmology administration from the Federal University of Sao Paulo, and this was followed by a PhD in ophthalmology at the same institution. Dr. Ventura currently serves as president of the Altino Ventura Foundation, and he is the academic coordinator of its residency and fellowship programs. He founded the Altino Ventura Foundation in 1986, and it is a nonprofit institution that has provided care to over 1.8 million underserved patients in Brazil. Dr. Ventura is a member of the board of directors of the Latin America Society of Cataract and Refractive Surgery and the Brazilian Cataract and Intraocular Implant Society. Dr. Ventura's achievements are far too many to list in their entirety, but he is a past president of the Latin American Society of Cataract and Refractive Surgery and the Brazilian Congress of Ophthalmology. He was selected as the honored guest for the 2015 ASCRS ASOA meeting. He has received over 30 medals and awards. He's published 22 books and book chapters, 96 papers and abstracts, and he has delivered over 200 presentations as an invited speaker. The final achievement I'd like to highlight is the establishment of the Liana and Marcelo Ventura International Fellowship in Pediatric Retina. And this is really a wonderful training program for international fellows conducted right here at Bascom Palmer Eye Institute with Nina Barakal. And this was made possible through generous philanthropic support from the Venturas through the Pan American Association of Ophthalmology. So the apples have not fallen far from the trees here, and Dr. Ventura's children are all ophthalmologists, and they have followed in their parents' footsteps. And pictured here are Camilla, Marcelo Jr., and Bruna, who are actually here in the audience today. And here's another family photo with Liana in the center, who is the matriarch of the family and a pediatric ophthalmologist. And she has also joined us here today. Their extended family is shown here on the right. Dr. Ventura will be speaking on global education challenges in ophthalmology. And please join me in welcoming him to the podium.
Good morning, everyone. My name is Marcelo Ventura. I live in Recife, a city on the northeast of our country, Brazil, right close to the coast. And to be here at this auditorium today, Jose Berrocal Auditorium, for me is a special moment. And I tell you that because I was his first fellow. He was my mentor. He was my friend. Besides teaching me so many things, he opened the doors for me to be a doctor that I am today. And to be here for this lecture honoring Diana and John Clarkson is a privilege, not to everyone, but to a few. So I'm very happy, delighted, and certainly I will keep this deep in my heart. Right? Okay. We heard many wonderful words about this couple, but I would add that this couple is an amazing couple. Besides everything Dr. John Clarkson have done, very distinguished eye doctor worldwide, they were wonderful people during their lifetime. And also still they are a good couple and good grandfather. And this is amazing. You can do and realize so many things and you still be part of your family. I'm talking now about some things that we have to recognize. To give a lecture at Bascom Palmer certainly is one of the most prestigious things that can happen to a doctor of ophthalmologist around the world. Thanks, Eduardo Afonso, for being a friend for many decades. Still we are young, but someone that I admire so much because to me, my family, Liana, Bruna, Camila, Marcelo Jr., and now my son-in-law, Murilo, we are all ophthalmologists. We are the third generation in my family. And in your name, I would like to extend my gratitude to everybody who works in this outstanding institution. It's a legend for the world, and I'm very happy, proud, and delighted to be here. Thank you. My topic today is global education, and we got to understand, first of all, how big is the problem? We do have three situations: developed countries, developing countries, and countries that are in deeply need. They are different. The areas are different, and how to reach these people should be in the different approach. When you are in a developed country, as you are here, we do have the best teaching sources, best professional, cutting edge technology, and things that you learn, of course, make differences in many ways. But for developing country, this is not so easy. But even though it's possible, depending on your chances. But when we talk about countries deeply need, that is another thing. And if we're talking about global ophthalmic education, we have to consider all these parts. The world is reaching almost 7.8 billion people. And still is increasing the life expectancy. What means that our problems will be bigger than is now. And it also means that everything we have done is not good enough. So we have to have strategies, changing what we are doing and make it better. When we think about vision loss, we will be very surprised. At least I am surprised, because 1.1 billion people still have impairment or blindness. And 1 billion of these people could be treated and prevented blindness or low vision. That is very, very important. And as we can see, we are not improving at all because the numbers are not as well as we would like to. Another point is very interesting because 90% of vision loss would be preventable and treatable. And it's incredible, but number one is uncorrected refractive errors. It means that most of these people could see better with just a simple glasses. On the other hand, cataracts, you have 100 million people that could see because they can, most of them, they can get a good vision result with a surgery. And what does it mean? It means that we have to spread more surgery than we are doing now and make it cheaper. This is very important if we want to reach every part of the globe. Another point that are chronic disease and of course need lifetime treatment and follow-up still is on our target. Plus 55 or 56 million still have lost vision to other causes. A lot of people. In this map, we can see that the vision loss is a global problem, even though we are talking about high-incoming countries. So we have 36 high-incoming countries, but we still have almost 74 million people with this problem. It's getting worse once you go to other part of the globe. This is very interesting. We are almost 240,000 ophthalmologists around the world, and this number is the median number for ophthalmologists per million inhabitant. And in the high-incoming countries, we have 80 ophthalmologists per million. But if you go to sub-Sahara area, you have just 2 ophthalmologists per million. That is very, very difficult for this area, besides many other things. And we got to do better than this. Brazilian Council of Ophthalmology, our president, Dr. William Lelis, which is doing an amazing job. We are 220 million people, and we are around almost 20,000 ophthalmologists. It is important to say that Brazil, we don't have optometry. So the ophthalmologists, they care about glasses too. And we are training 98 institutions are training ophthalmology in Brazil. And every year we have around 500 more ophthalmologists in our country. Vision loss, of course, is a result of social inequalities. As you can see, 9% of these people, they live in low and middle income country, and the age and women are, and children and girls are a little bit more affected by this. We have to pay the bill, and vision loss and low low vision or blindness, we are wasting money, something around $410 billion a year. It's very important. Prevention, education, and somehow do less money, do more with less money. That is really important. We have some tools and something is really important. When you are at Bascom Palmer, usually people don't even know the problems around the world. I'm quite sure that the Bascom Palmer Eye Institute have an overview of the world, but it's difficult to live the problem itself. But we do have internet, telemedicine, AI, and global actions. For we to understand the size of the problem, maybe 2/3 of the world still don't have any access fresh water, food, of course, internet, and all the things. It's coming, but we have to spread them out to make much better work. These tools make access for the informations, and by this, we can make the difference smaller than is now. I agree with this, and everybody's work on that. Some global international organization, they are doing a lot of things. Good institutions are trying to do their best. And I understand that even though something else should be done. And let's see why. We do have some things very special for training and for global education. But again, we need infrastructure for all these things work. But let's say that we do have achieved this, and that is something that makes a lot of difference, and I want to share our experience. Surgical simulators. This is very good. We have improved a lot in our institution. Our residents are more confident. They have learned much more before go to human eye. We have less complication. The patient is much more safer on a training course, and they exist. They are very expensive, takes time to buy, but they are extremely good for teaching programs. And I'm quite sure that we have to spread this out, dry and web lab for other institutions. Courses, again, online courses, of course, they exist, they are wonderful, but again, we need infrastructure for many people in the world or many countries. But once we do have this, I believe very much that it's a reality not for everybody, but is a reality. And an AI could help very much. It's starting. But I believe, as an example, we need a problem that is language. No, even though many people speak English, English is not the first language in the world, because we do have Chinese and many other populations speaking other languages. But I believe very soon that we're going to have translation in real time. That would be a very good possibility to spread knowledge worldwide, because people will understand once they have at least some technology to understand. Today, even though if they don't understand, or most of the people can't understand the courses, online courses in English, let's say. And if they want to get any questions, of course, they don't speak English, but if you have a real-time translation, would be possible. I think this will be soon out in the market. We also can get interaction with professor, and with Bascom Palmer, we can get some good informations using these courses in internet. Education programs, we do have residency, observership, and fellowship program as usual. We do have guest professors and medical students rotation. That is very important in my opinion. You know why? Because when you have medical student rotating our institutions, you can trigger their desires to be ophthalmologists. You can get the first experience, even though they are not ophthalmologists, still are not. So we can have many students going to see the first step, what is ophthalmology? And I think it's a great idea to involve these people, maybe to become eye doctors. Exchange programs that I will tell you my story later on are very, very important to connect people, transfer experience, to learn, meet people. And that is, I think, very, very important on the way. Here comes the difficult problem, is the low income countries. This is Brazil. Brazil is a country that you have both sides. You still have a lot of poverty. We still have a lot of poor people. And we do have problem like Africa. In Brazil, we are getting better, but we still have a lot of problems and some barriers, because they have barriers, and we do have barriers in Brazil too. So lack of technological and financial resources, language. And we speak Portuguese. So if people want to go to Brazil, just talking English will be not possible, because the universities, the hospitals, they don't speak English. Some doctors, yes, few doctors, but that is not enough for being an exchange program. We should learn, it's very important, how to make things possible, spending less money. Once you are here at Bascom Palmer, you can have everything, the best you can get in the world. But if you go to any low-income country, even if you are excellent surgeon, phaco, retina, probably you won't do many things on those countries. Why? Because they are unable to offer you the technology that you are used to. So low-cost solution is crucial. And how we can get low-cost solution if we just know high, outstanding surgeries and cut-edging technologies? This is a good question. So just to give you examples, I don't know if you have read about Artavine in India. This institution is unbelievable, and a surgeon can do 10 up to 15 cases an hour of cataract. And why they do that? Because they standardized all the procedure. The surgery just do, they don't clean the operating room for every case. They don't change it. Well, it's different. If you see one day, but it's possible they are doing 450,000 eye surgery per year. So it's something that we have to know that exists. We are not talking about if it's right or wrong. We are talking about what is possible to help more people. We do have some strategies. If you talk to, here is the institution that is very worried about global education, and we have strategies, and we have to think about what is possible. I will show you that this is not mine, but everything's written here. It's easy in some places. In other places are impossible. So again, interactive online courses. How would be possible if you don't have internet? But well, internet, everybody has internet. I have 2 iPhones. Everybody has everything. It's not true. So if we are talking about global education, we have to understand that we are not at Bascom Palmer. So we have different things that can already be done or are done. But from this, I would say that I will put my money on, and I will bet in the number 7, the telehealth or telemedicine. I think this will be a very good tool for helping people, especially people that are in the middle of nowhere. We're gonna get some results on this way, at least is my opinion. Let me tell you what is global education, and please, I would like to show what I've done and how it's possible to believe in global education. Believe or not, this is me, 1977. So I was ugly at that time, but now I'm much better. All right, so I was in Recife, 4th city of Brazil. 2 universities at that time. We didn't have a regular course in ophthalmology. So I had to flew to São Paulo and had my residence course there. And then, again, what is global? I had a chance to go to Houston, 1983, to take a patient to Baylor College, McPherson's service associated. And there I was very lucky because I met Dr. Milton Boniak and also Douglas Koch. For first time in life, I could see phaco, I could see ECCE, and I saw the first IOL implantation. At that time in my country, we had just intracapsular technique. So I was so surprised. And I said, well, if this is working on American eyes, Why not is going to work in Brazilian eyes? It will depends on me. I got to learn and depends on the surgeon. The tools are the same. We have to learn. My first IOL was 1984. Maybe some of you was not, most of you were not born yet. Then I went to Puerto Rico. This changed not only my life, but changed millions of lives, and you understand. I was for a fellowship with Dr. Jose Berrocal, that named this auditorium, and I did a fellow in retina and cataract. At that time, I had a chance to see different things that I was used to. He was my mentor. He was my friend, gave so many opportunities, not only in Puerto Rico. I'm very thankful for him. I have good memories, and he had so different good things in my life that I can't forget. Neither him, neither his family. I had a great time in Puerto Rico. This is global education. I had so much good time in Puerto Rico. So my wife, Liana. And again, Dr. Berrocal, he was a chairman at the University of Puerto Rico at that time, and gave Liana the opportunity to take a fellowship in pediatric ophthalmology when I was in my fellowship. For you to have an idea, pediatric ophthalmology we didn't have in Brazil. So she was the first pediatric ophthalmologist in Brazil. Went back to Brazil, and now she has many, many fellows, and now even pediatric society exists in Brazil. But that was a beginning, and this is important to talk. He was under the mentorship of Ramon Portela, that it was some special people in her life. Then I had the chance to meet renowned doctors at Guillermo Picot basic course at the University of Puerto Rico. One of those people was Edward Norton. And then back now we come to Baskin Palmer. And also Stanley Sheng, that is in New York. These people, and I'm going to tell you what happened. Here is, again, Berrocal would get me observership in 1986. And this is Dr. Baskin, this is Dr. Norton. On his side is Dr. Eduardo Afonso, assistant professor at that time. And he knows, Dr. Norton knows, that I had a dream. I would like to go back to Recife and teach ophthalmology. This way, I was quite sure that people from my hometown or area would not leave Recife to learn ophthalmology or to become ophthalmology. So Dr. Norton knew that, and a few days before I leave back home, he called me up to his office. The resident, you don't have no idea what was be called to Dr. Norton's office at that time. It was too difficult. So what did I did wrong? No? I was very scared to be there, but he called me up and said, I know you want to teach. You belong to any university? No, but I want to teach. Okay, what you need? Anything? And he gave me hundreds of slides at that time from Baskin Palmer Library. And that's the way I start my course, residency course in Brazil. So I want to make sure that I'm very grateful for this, for Baskin Palmer, for this man that was looking ahead. And I tell you that this is global education. So I had a chance and I went back to Recife and I start teaching. If was not this way, would take me much longer to start doing something in ophthalmology. So thanks, Baskin Palmer. Thanks, Dr. Norton. In 1987, I flew to New York. Again, Dr. Jose Berrocal gave me a chance, and Stanley Chang was at the Cornell University at that time. Now she is in Colombia. He is in Colombia, sorry. And for first time, I was a retina guy, and for first time, I could see perfluorocarbon, endophotocoagulation, and wide-angle system to see the retina. You don't know how was do retina with wide-angle system. You could not see very. So I'm very grateful to Stanley. Thanks, Stanley, for your support and for your friendship. What do I believe? I believe in this triangle: easy, education and research, patient care, and sustainability. Let's see, let's see how we could change in our area of influence and bring global education into our reality. So I had a chance, I took my chance, and I tried to spread what I could do to other people that didn't have the chance I could get. We had two main points. We had to have a private institution and a teaching institution. The private institution is Hope, and the teaching institution was Foundation, Altino Ventura Foundation. In the triangle, we need to have sustainability and also teaching. This is Hope today, but what most important is Altino Ventura Foundation could exist in 2021. We finally had our headquarters. And why this is important? Because now we can see people proper in the best way. People are welcome and they have seats and they can have many other things. So patient cares. If we do have everything, we need to help people. Not only for helping people, but just because you gotta teach people too, the residents and people that are coming in, are visiting us, are trying to understand or to try to learn more. We need numbers. So we are located at the north, in the northeast of Brazil. In red is Pernambuco State. These are our number today. Our area of influence is 55 million people. Even Brazil has 220,000 million. And we are very grateful to some people, but we cannot forget volunteers. I am volunteers. My wife is volunteer for 37 years at the foundation, my family. But we do have amazing number of 190 volunteers at our institution. We do have a very good facility. Even though people don't pay, we have to have support for other resources or other sources. But it's amazing how we could change the place where we didn't have anything in ophthalmology for this situation now. This is result of global education. We are running 200 surgery a day, and we will step forward. We will do more than that soon. So, education and research. We have graduated more than 700 eye doctors, ophthalmologists from all Latin America. Again, why we are in Latin America? For the language. So if they speak English or Russia or Chinese, it would be very difficult to come over. And now we were a few years ago just in a small corner of Brazil. Now we are spreading global education to Latin America. I want to present this because I'm quite sure that Berrocal would be very glad, and also Dr. Norton, to know that these are my personal fellows in retina. They are spread out in Brazil, in Latin America. So now I'm happy because once I was talking to Berrocal and said, listen, oh, Stanley, but I have so much and I don't have any words in English to say, hello, I owe you many things, because I knew what I have learned. And he told me, if you want me something, teach. If you teach everything you know, we are tight. You paid what you owe me. And he said, that's very easy, but it's impossible. Because when you teach, you learn. Then you have to teach again, and you learn again. So you have no way to pay this debit. So I'm very happy because I myself, every one of these people were on my office, were on my surgical day, and this means very much for me in respecting all the people that helped me a lot. We do have experience in mobile unit. We have done 35,000 eye surgery, most of this surgery in the middle of nowhere. We had a program for sponsored by Rotary Club International, and was amazing the result of this, because people could get eye surgery, phaco surgery, and go back to their home. If you are 500 miles away, you can imagine how difficult it is for these people. They don't have car, they don't have where to stay. So if you go close to where they live, they go back to their home. Doesn't matter if it's nice or simple home, but they will sleep at their home. Then we decide to have not because we had some problem in COVID, and so we decided to spread the units in our countryside that is doing okay. We are helping people in the same way. They don't come to Recife anymore. And then came the rehabilitation center. That is sustainability. We have people that are helping us all the way. And the rehabilitation center, that is very important in many ways. We have different parts in partners. CBM, Germany government, Lions, RTL, that is the television, the biggest television in Germany, and Chapolimo Foundation from Portugal. What happened to the rehabilitation center? We have visual, hearing, physical, and we have already expanded the service to 8 states of Brazil. This again is global education. You are spreading to where it's possible. Research. That's, for me, it's very important. It's hard to do research in some places, especially out of the United States. But we have a very active research department coordinated by Camila Ventura. And we have published many papers, and international and nationals. We have Zika. syndrome, Recife was the epicenter of Zika in the world. We had 208 cases of Zika, and we are still following these children. We have published, Camila was fellow, Nina's fellows at Baskin Palmer, and they published the first cases of Zika in the US in 1918, I think, right? So we do have very special, and we are very grateful for people who believe on our work. We have a R01 grant to make a 5-year longitudinal study on neurological development for Zika patients. And we have published many papers, like more than 50 about Zika. I'd like to make a comment. We are very happy to have a Brazilian researcher here, Felipe Medeiros. Congratulations, because you are representing, of course, all of us, and we are very proud of your work. So what I believe that you have to dream big, especially the young people. Discipline, focus is important. Never give up of your dreams. If you don't have dreams, you won't survive for long. If you do have dreams and you do have perseverance, focus, discipline, and you never give up, you will be happy in your family and you will accomplish a lot of things. So sustainability, we do have many people to help. Thanks God for so many hands that are helping us in our job. We have international partners and Brazilian partners and industries that make all these things possible. Here is my family. We are in the 3rd generation. We are all involved in global education. And we are returning to receive to make this knowledge be spread out. 1914, Bruna went to Baylor College. 2017, Camila came to Baskin Palmer. Thanks everybody that she had a great time, learned so many things. Thanks all you all. And Marcelo Jr., he was in Chicago, Los Angeles, and now here in Baskin Palmer. I'm very happy that my family has the opportunity to learn in so many ways and get a chance. Thanks for the chance. Once you get a chance, you have to take it as the unique possibility in your life. Don't waste your time. Take the chances and make it possible to be useful. Acknowledgement, I have a lot. So, but I would say that I'm very surprised for people that are volunteers because they go every single day. They don't make any money. In Brazil, we cannot pay even the transportation. We can't pay them food. I don't know why, but this is the way, but they still are there. They make difference, and I would like to honor them because I think that is not usual in our culture in Brazil to have such amazing people around. Well, I would like, after all, I would like to make a special tribute to Berrocal family. Thanks, Nina. Thanks, Maria, to be here with us. And in her name, I would like to honor all my profession and institutions that I have been, that have trusted me and make the doctor I am today. So I also would like to thank my friends. When you have friends, your life is much happier and lighter. So don't be alone. Take your time to make friends, connections. And now I would like to say thanks to you, Eduardo Alfonso, whose career show he's committed to his family. It's important for me because, as I told, it's difficult to be amazing doctors and you have amazing family. That is very, very difficult, but it's possible. Yes. Here in 1983, he was a fellow and was reading for his daughters. This book, I think I have it too, because we are almost the same time. And I want to congratulate Molly for supporting you as well as possible along your career. When we do have a wife or husband supporting us, we go much more farther than we think it's possible. And in the name of Eduardo Alfonso, I'd like to honor all international leaders who opened the path to our generation, to the next generation in the world. Okay, so again, the next slide, please. All right, then, of course, I'm happy and I've done so many things because I have a lovely wife. She's over there. Isn't she lovely? And well, also, I want to thank my family, my support of my daughters, Bruna, Camila, my son-in-law, Burilo, that they are all here. Thank you for coming. And my granddaughter and my grandson, Marina, Rafael, and Burilo. Life would be the same if we don't have these people around. And thank you so much for the opportunity. I'm very happy. I'm blessed. I'm delighted and honored to be at Bascom Palmer. I tell you, I came twice, more than twice, but I came twice in Bascom Palmer, one with Norto that changed my life and the life of many people. And now I come here and I'm changing my life. I will take this message to home. I will keep deep in my heart. Thank you very much, Eduardo Alfonso, for the opportunity. I'm very honored to be with you. Thank you.
Stay here a second. Any questions or comments? Eliana, you can stay here too. I think it's wonderful to have this level of mentorship and inspiration for all of us. And certainly I know I speak on behalf of our residents, fellows, and other trainees who are here, that to see your path and how you have dedicated yourselves to improving the lives of others through what we all aspire to be able to do: clinical care, education and research, and community outreach. And that's the mission statement of the Bascom Palmer Eye Institute. I'm sure is the mission statement of the Altino Ventura Foundation, and of any one of us who feel that we have a mission in life. So thank you so much for being here. One big round of applause. And I'd like to honor your visit with a couple of things. And I think they're here. Let me see. There we go. Perfect. So we have the diploma that Dr. Norton forgot to give you when you were here. So So he called me last night
Oh, right.
and he said, you know, he forgot to take his observership diploma. So we have the diploma for you. And we also have a couple of things, a book on the history of the Bascom Palmer Eye Institute. And I apologize that the memento that we give all of our guest speakers, and this has been a tradition for many years now, that you can have this box to put some of your memorabilia in it, has May 23rd, because I know we changed the date, but now you're going to be coming back on May 23rd to give another lecture.
Oh, thank you.
No, we'll change it for you, but thank you. Don't worry, I have all the money that I have in the world with zero. Thank you. I'd like to ask the rest of the Ventura family to come and join us. If you can all come up here, it would be great. And thank you. So maybe we can all come up and I really want to give you all a great round of applause for what you do for these two folks that really depend on all of you to be able to be here. So thank you. Sure.
I'd like to leave this plate that is something important for us from the foundation. It says, the Altino Ventura Foundation is honored to pay tribute to Bascom Palmer Eye Institute, whose visionary effort and significant contribution have sustained enhancing the ophthalmology training offered at Foundation Altino Ventura. These efforts have positively impacted the lives of over 700 ophthalmologists that graduate from our institution along its 37-year, and there is my signature.
Thank you. Thank you very much. Thank you. And I know that John Clarkson is in the audience with his wife, Diana. And John, Diana, thank you so much for all you have done for the Bascom Palmer Eye Institute over the years. And I'm sure you've enjoyed this lecture tremendously. I'm sure I'm going to hear from John. As soon as we get off here, he'll be sending me a text message and say, great lecture. So thank you, John and Diana, for hosting this. And thank you to our other great friends and supporters who are here. Certainly, Jose Berrocal, without him, none of us would be here. And I'd like to ask Maria and Nina to join me up here so we can have a nice picture of the extended Ventura family.
Yes. All right, thank you everyone for joining Grand Rounds today. That concludes our session, and we'll see you next week with more cases. Have a great week. Take care.
And for those of you here,